So if a doctor tells you that your pelvic organs are, physically falling, your instinct is probably to assume that everything down there has just become really loose.
Right. Yeah, that makes sense intuitively.
But we're seeing new clinical data that suggests the exact opposite for hypermobile patients. Like that profound loose feeling might actually be the sensation of your muscles clenched so hard that they are completely exhausted.
Yeah, and it completely flips standard biomechanics on its head. I mean, we usually
Yeah.
view the body as a machine with very obvious, localized, broken parts. You tear a ligament, you feel pain, the doctor points to the swelling, and then you just fix it.
Right. It's usually very straightforward, but the pelvic floor kind of throws that mechanical clarity right out the window, especially when connective tissue disorders enter the chat.
Oh, absolutely.
You've got patients feeling one thing, doctors seeing another, and then standard advice like, just do Kegels, sometimes making the whole system actively worse.
Which is terrifying for the patient.
It really is. So, okay, let's unpack this. We are pulling from a fascinating stack of sources today for this deep dive. We've got clinical guidelines from the Cleveland Clinic and the Royal College of Obstetricians and Gynecologists.
Mhm.
We have a brand new 2025 dynamic MRI study from the CME journal Geriatric Medicine, plus specialized physiotherapy blogs, and even some raw personal accounts from the hypermobility Reddit community.
It's a really diverse set of data.
Yeah, and our mission today is to decode this highly specific, kind of misunderstood, and frankly sometimes taboo question. Can hypermobility make pelvic organ prolapse feel like vaginal laxity?
Well, addressing that means we have to look at the literal building blocks of the hypermobile body.
Right, the actual blueprint.
Exactly. So in conditions like hypermobility spectrum disorders or HSD and Ehlers-Danlos syndrome or EDS, the collagen is just structurally different.
Okay.
And collagen is essentially the glue holding the entire pelvic structure together.
I feel like we all know the Brighton score party tricks, right? Like the backward knees or being able to bend your thumb all the way to your forearm.
Yeah, the classic screening tool.
All right. But the sources push way past that surface level hypermobility and go right into the pelvic floor because people often forget that the pelvic floor isn't just a muscular hammock.
No, not at all. It relies incredibly heavily on connective tissue.
Okay, so break that down for us.
Sure. So you have these major ligaments, like the uterosacral and cardinal ligaments, plus this vast web of fascia. And all of that is supposed to suspend the bladder, the uterus, and the rectum.
Suspend them like a trampoline.
Yes, exactly.
Yeah.
But if we connect this to the bigger picture, in EDS, that collagen is more elastic and way less resilient. It just doesn't snap back.
So it's basically like trying to build a house but using rubber bands instead of steel beams for the foundation.
That is a perfect way to describe it. You're trying to suspend heavy organs using bungee cords instead of static, high-tensile cables.
Wow. So under the constant pressure of just, existing gravity, coughing, laughing, daily movement, those bungee cords are just going to stretch out.
Yeah, they give way. The very tissue that is meant to suspend the organs is fundamentally weaker from birth.
Which has to be incredibly confusing for the person experiencing it. Because those rubber bands are so stretchy, the physical sensations get all mixed up. So let's clearly define the difference between laxity and prolapse based on the medical literature.
Good idea. Let's start with vaginal laxity.
Okay?
The medical literature defines vaginal laxity purely as a loss of tone or tightness in the vaginal walls.
Right. So symptoms would be a feeling of looseness, maybe decreased friction during intercourse, reduced sexual satisfaction, and what they call vaginal wind.
Yes. But the crucial part here is that laxity involves minimal to no actual structural dropping of the internal organs. The organs are still where they belong.
Okay, got it. But prolapse is an entirely different beast.
Completely different. Pelvic organ prolapse, or POP, is a structural condition. It's when the organs, like the bladder, rectum, or uterus, actually descend into or even beyond the vaginal canal.
And the symptoms for that are a lot heavier, right? A visible bulge, severe pelvic pressure, a dragging sensation that gets worse when you stand up, and difficulty emptying the bladder or bowels.
Exactly. And the 2025 dynamic MRI study really brings this home. They looked at 50 women and actually measured these mechanics in real time while the patients were straining.
Oh, wow. So real-time data on the organs dropping.
Yeah, the data definitively proved that prolapse involves a measurable physical widening of the structural gaps in the pelvis.
Right, they measured the H-line, right?
Yes, the H-line, which is the levator hiatus, basically the front to back dimension of the opening in the pelvic floor.
And what did the numbers look like?
In women with prolapse, that gap averaged 6.2 centimeters.
Okay, and for those without prolapse?
It was 5.1 centimeters.
Wait, really? Over a centimeter of widening in a space that small?
Yes,
That's massive. That's like a 20% increase in the structural gap.
it is. Functionally, the trapdoor is opening so widely that it compromises the entire structural floor, and that allows the organs to just slip right through.
Unbelievable.
And the study also tracked the M line, which measures how far the levator plate actually drops under pressure. Those numbers showed a severe physical descent. It completely removes the shelf of support those organs rely on.
Okay, so here's where the trap kind of closes on the patient. Because the clinical guidelines state that patients who have prolapse also have a very high incidence of vaginal laxity.
Right, the sources explicitly highlight that intersection.
Yeah.
While laxity isn't necessarily an early symptom of prolapse, the two conditions frequently coexist.
So the loss of tone and the structural dropping are happening at the exact same time.
Yeah, exactly.
And you see this play out so tragically in patient communities. Like, there was this 40-year-old Reddit user from the hypermobility subreddit.
Oh, I remember reading that account.
Yeah, she was trying to conceive and was completely unaware of what was actually happening. She spent her entire adult life dealing with extreme, quote-unquote, queefing, a profound loss of partner sensation, and severe bloating.
And she thought it was just natural looseness, right?
Exactly. She assumed her body was just aging or changing. She had no idea that a structural collapse was happening. The organs themselves were physically descending into the vaginal canal and blocking the sensation.
It's heartbreaking, but here's where it gets really interesting, structurally speaking.
Okay, pushback time. If a hypermobile person feels loose, how on earth do they know if it's just tissue stretching laxity or an actual organ dropping? Because, their faulty collagen is the root cause of both, right?
That is the million-dollar question.
Yeah.
And answering it leads to probably the most mind-blowing and misunderstood finding in our entire stack of sources, the hypertonic pelvic floor.
Okay, explain that.
So, because the hypermobile ligaments and joint capsules are too stretchy, they can't provide passive stability.
The rubber bands are failing.
Right. So the nervous system senses that the pelvis is unstable, that the joints are slipping. It essentially panics. And so it recruits the muscles to do the job of the ligaments.
Oh, man. So it's like, okay, imagine you're carrying a heavy, overstuffed grocery bag. You're walking to your car, and the paper handles, which are the ligaments in this scenario, snap.
Okay.
So you grab the bag from the bottom with your arms, clutching it tightly to your chest. Your arms are the muscles. If you have to carry that bag for a mile, your arms are going to get absolutely exhausted.
Oh, they would be burning?
Right. They'll cramp up and shake because they were doing a heavy, sustained job that the handles were supposed to do effortlessly.
That is a brilliant analogy.
Yeah.
And that is exactly what happens in the hypermobile pelvis. The muscles are forced into this constant low-grade guarding.
So they're just working overtime, 204/7?
Yes. Pelvic floor muscles are not designed to hold joints together all day long. They are meant to contract, to maintain continence, and then release.
So this constant guarding leads to a hypertonic or overly tight and spasming pelvic floor.
Exactly. And the cruel irony here is that the symptoms of a hypertonic pelvic floor perfectly mimic both laxity and prolapse.
Wait, really? Being too tight feels like being loose.
Yes, because the muscles are so tight and fatigued, they can't relax to let urine or feces out, so you get incomplete emptying and urinary urgency.
So the patient feels a lack of sensation or support, assumes they are overly loose, but they are actually clenched into a rigid knot.
Precisely. And this is why penetration becomes incredibly painful. The muscles are guarding a vulnerable area. In fact, the sources note that dyspareunia, severe pain with sex, is reported in up to 64% of hypermobile EDS patients.
64%. That's huge.
Yeah, alongside very high rates of vulvodynia, which is chronic vulvar pain.
Wow. Okay, so this completely exposes why the standard medical advice is so flawed. A woman goes to her general practitioner complaining of feeling loose or maybe having some mild incontinence, and the automatic reflex is to say, just do Kegels.
Right. They prescribe core strengthening and pelvic floor clenching. And what's fascinating and terrifying here is that for someone with EDS and a hypertonic pelvic floor, prescribing Kegels is actively harmful.
It's like telling someone with a severe calf cramp to stand on their tiptoes.
Exactly. You are adding maximum tension to a system that is already failing from pure exhaustion. You're asking muscles that are shaking from carrying that heavy grocery bag to grip even harder.
So you're diligently doing your prescribed exercises, thinking you're helping, but you're actually accelerating your own structural collapse.
Unfortunately, yes.
And the Pelvic floor doesn't exist in a vacuum, right? The sources show that surrounding bodily systems are directly feeding into this mechanical nightmare. It creates this vicious cycle of
Bro,
comorbidities.
heavily. The hypermobile body is highly interconnected, and the gastrointestinal system is a primary offender here.
Right, because hypermobility affects gut motility.
Yes, it affects the smooth muscle and connective tissue in the gut wall, leading to significantly slower digestion.
Which leads straight to chronic constipation.
Exactly. And so you have daily repetitive straining on the toilet. That puts immense downward pressure on an already fragile pelvic floor.
So the patient is literally pushing their organs down through that widened structural opening we talked about from the MRI study.
Yes, it directly worsens a prolapse and further exhausts those hypertonic muscles.
Okay, and then you factor in the autonomic nervous system. The sources highlight POTS, right? Postural orthostatic tachycardia syndrome.
Yes, which is highly comorbid with EDS.
So how does POTS play into the pelvic floor?
Well, POTS is a form of dysautonomia. When a patient with POTS stands up, their stretchy veins allow blood to pool in their lower extremities instead of returning to the heart.
So the body panics again.
Right. To pump that blood back up to the brain and prevent fainting, the body dumps massive amounts of adrenaline.
So it puts the body in a heightened fight or flight state just to keep the person conscious?
Exactly. And when your brain thinks you are constantly under threat, your muscles tense up defensively. That adrenaline flood directly drives the chronic muscular tension in the pelvic floor.
Wow. So the nervous system is essentially using the pelvic floor as an auxiliary cardiovascular pump, forcing it to squeeze to help move blood upwards.
That's right. And this constant sympathetic overdrive irritates the bowel and increases urinary frequency or IBS symptoms. It creates a brutal feedback loop of pain and clenching.
And the neurological disconnect gets even wilder when you look at the proprioception deficits mentioned in the physiotherapy sources.
Well, the internal map issue, yes.
Right. So connective tissue is packed with mechanoreceptors. Those are the tiny sensors that tell your brain where your body parts are in space and how stretched a muscle is.
But if the collagen housing those sensors is overly stretchy and lax, the data sent to the brain is completely distorted.
It's garbage in, garbage out.
Exactly. Hypermobile people literally have a harder time sensing where their body is in space. Their internal map is blurred.
There was this incredible anecdote in one of the clinical PT blogs about a patient undergoing biofeedback therapy.
Oh, I know the one you're talking about.
Yeah, so they had physical sensors hooked up to their pelvic floor to monitor muscle activity, and the patient looked at the biofeedback monitor and just burst out laughing.
Because the screen showed something completely different than what she felt.
Right, the graph showed a massive sustained muscle contraction, but the patient genuinely, physically felt completely relaxed.
Her brain simply wasn't registering the clenching.
Exactly. They might be actively pushing against a closed sphincter when they think they're relaxing to go to the bathroom.
So we're looking at a patient who cannot accurately feel their own muscle spasms, whose autonomic nervous system is flooding them with adrenaline to force those spasms, and whose sluggish digestive system requires constant straining against fragile ligaments.
So what does this all mean? How can anyone possibly break that cycle? Every single system digestion, spatial awareness, autonomic responses is actively fighting against the pelvic tissue.
Well, you have to throw out the standard playbook. You have to look at highly specialized treatments that actually respect the delicate nature of the EDS body.
Which means rethinking surgery.
Absolutely. The clinical guidelines emphasize that surgery must be considered an absolute last resort.
Because of the tissue fragility. I mean, when a surgeon cuts into EDS tissue, it doesn't behave or heal like normal tissue.
No, it doesn't. The sutures can literally pull right through the fragile fascia. It's often compared to a wire pulling through soft cheese.
Oof, that's a vivid image.
It's grim, but it's true. Suture failure, incisional hernias, and severely delayed healing are massive risks. Take a common procedure like a sacrohysteropexy, where a synthetic mesh is used to pull up and support the prolapsed organs.
That's pretty standard for non-EDS patients, right?
Yes, but EDS patients face a much higher rate of complications with it. The mesh is rigid, but the EDS tissue is extremely pliable.
Oh, I see where this is going.
Yeah, the constant friction causes the rigid mesh to slowly erode directly through the vaginal wall.
That sounds agonizing.
It is, and it requires incredibly complex revision surgeries.
Okay, so if surgery is pushed to the back of the line as a last resort, what's the first line of defense?
Pessaries. They are removable silicone or rubber devices inserted into the vagina.
They basically act as a prosthetic scaffolding for the prolapsed organs.
Exactly. A well-fitted pessary gives an EDS patient crucial structural support. It physically holds the organs up, and that finally relieves the burden on those exhausted, spasming muscles without the trauma of surgery.
That sounds like a game changer, but there's a caveat, right?
Yes. Hypermobile tissue is incredibly delicate, so the vaginal mucosa can easily tear or ulcerate if the device isn't fitted perfectly. It requires experts, ongoing management.
Right. And structural support has to be paired with specialized physical therapy?
Crucially, yes. But a hypermobility PT specialist isn't going to start with Kegels or concentric
Yeah,
contractions.
more squeezing.
Right. They start by downtraining the nervous system. The immediate priority is teaching the brain to actually release those hypertonic muscles.
So focusing on things like diaphragmatic breathing.
Yes, and eccentric lengthening. Teaching the pelvic floor to stretch and drop on the inhale. They work heavily on managing intra-abdominal pressure so the patient can cough or lift or move without bearing down on their pelvic floor.
They're essentially rebuilding that internal proprioceptive map so the patient actually knows what relaxed feels like.
Exactly.
But wait, what about those high-tech treatments we see advertised specifically for laxity? Like, clinics are aggressively promoting thermal lasers or radiofrequency treatments like Emcella to quote-unquote tighten things up.
Well, this raises an important question about exactly what is being treated. Those technologies are designed solely to stimulate collagen production and improve the tissue tone.
So they are treating the laxity of the vaginal wall.
Yes, they cannot, under any circumstances, fix the physical descent of a prolapsed organ.
Got it. So if your bladder is physically dropping into the vaginal canal because your ligaments have stretched out, a cosmetic laser treatment to tighten the vaginal skin isn't going to somehow push the heavy bladder back up into place.
Not at all. Treating only the laxity when you have a structural prolapse leaves the root mechanical problem completely unaddressed.
Which just emphasizes how critical and accurate diagnosis is.
Paramount, whether that's through a highly specialized VT assessment or advanced imaging like that dynamic MRI we discussed. You must know if you're dealing with a muscle spasm, a tissue tone issue, or a structural collapse.
Right, because treating a structural descent with a laser or a hypertonic spasm with Kegels only deepens that cycle of pain.
Exactly, it's a diagnostic trap.
So to bring this all together for you listening, if you, or maybe a partner, have ever felt off down there, if you've been dismissed by a doctor and told you're just loose after having kids, or if you struggle with unexplained pelvic pain, pain with intimacy, and severe bloating,
The answer might literally be written into your connective tissue.
yes, your physical sensations are real. A systemic connective tissue issue is not a failure of willpower, and it is certainly not just in your head.
It's structural and it's neurological. The standard advice you've been given to strengthen your core or push through the pain might be the exact wrong move for your specific anatomy.
Exactly. If you suspect you are hypermobile, you need a care team that evaluates your whole body, your joints, your gut, your nervous system.
Because they're all pulling on the exact same stretchy tissues. Understanding your own structural blueprint is the only way to effectively navigate these overlapping symptoms.
And avoid treatments that do more harm than good.
Precisely.
You know, we spent this deep dive talking about how the nervous system stays in a constant state of panic, forcing the pelvic floor muscles to brace and guard against loose joints. But I want to leave you with a broader thought to kind of chew on. Think about the implications of that muscular guarding. If your brain is constantly subconsciously forcing your pelvic muscles to grip and clench just to stabilize your hips and organs, what is it doing to the rest of your body?
That's a huge question.
Right. What if this constant low-grade muscular guarding across the entirely hypermobile body is a major unrecognized driver of chronic fatigue? Just imagine the sheer caloric and mental energy it takes for your brain to manually hold your skeleton together 24 hours a day without you even realizing it.
The physical toll of that hidden labor is profound. And honestly, it really explains why exhaustion is such a universal experience in this patient population.
Absolutely. Something to think about the next time you feel utterly drained for seemingly no reason. Keep questioning, keep learning, and we'll catch you on the next deep dive.